Good afternoon. Today is Thursday, January 16th. We're going to start today with a briefing from the Health Department, and then after that, we'll do 6 bill hearings. So if I can have whoever from the Health Department is going to join us to talk about DDA self-directed services. That's the first agenda. Madam Secretary, good afternoon.
Good afternoon, Madam Chair, Vice Chair, congratulations. Good afternoon, members of the committee. So we have several presentations for you, so we'll be rotating who's at the table if that works. Here's the...
Secretary, will you pull the mic a little closer? It moves. There you go. Thank you.
My mother always told me to use inside voice. Nobody's told me to bring the mic closer.
There's not here today.
So this is the list of topics that we're going to be reviewing today, starting with DDA self-directed services updates, and then we'll go over Medicaid, specifically redetermination and updates around the MCOs. You'll hear after that the Office of Healthcare Quality. I'll spend a little time talking about MDH overall staffing and the vacancy rate, which was a request from this committee, and we'll give an update on where we are on that. And then last, the Behavioral Health Administration, specifically around licensure of substance use disorder programs. So with that, I will turn it over to Deputy Secretary Hutchinson to give the update on DDA self-directed services.
Good afternoon, Madam Chair and Mr. Chairman, and esteemed committee members. Today, I'm going to talk with you all about, just provide a brief overview of the self-directed services updates that we have underway with DDA right now. Just want to really highlight how self-direction allows for greater choice and control for individuals, and how our program must be thoughtfully designed so that we can sustain the program. So our key takeaways today will be around how the state has been responding to stakeholder feedback regarding the inconsistencies and lack of clarity, and the manner in which we published our clear and unified standards. We're going to talk about, as our waiver program evolves and expands, that the infrastructure must be in place in order for us to make certain that we support participant self-determination regardless of service delivery model. And in doing this, we need to make certain that our standards are clear, because it is essential for us to provide quality services and ensure program integrity. So just to go into, need to back up here. So just to go into a brief introduction about Medicaid waiver programs. Currently, Maryland operates 8 1915C Medicaid waiver programs, and DDA operates 3 of these programs on the Medicaid program's behalf. They are community supports, community pathways, and family supports. In order for an individual to participate in these programs, they must qualify financially, technically, and also medically upon enrollment and on an ongoing basis. And when we say an ongoing basis, individuals must go through a recertification process at minimum annually. In DDA, we provide 2 service delivery models. One is a model that is referenced as the traditional services delivery model that is actually operated by our community providers. And the second model is our self-directed services delivery model, where the actual participants in the program are the ones who hire, fire, train their staff. They act as the employer of their services. And individuals within the self-directed services delivery model have budget authority, which means they control how their money is spent within their approved budgets. Medicaid waiver programs within that 1915C authority that I referenced earlier must be cost neutral. That is a federal requirement when the state petitions CMS to operate these programs. And what that means is for the developmental disabilities Medicaid waiver programs, that means that the institutional alternative is an intermediate care facility for individuals with intellectual and developmental disabilities. The Medicaid program cannot pay more for institutional, for home and community-based services than it would do for institutional services. So that's what we mean by these Medicaid waiver programs must be cost neutral. Earlier, I spoke about the two service delivery models that we have within our 3 DDA-operated programs. And again, just want to go over the fact that the self-directed services delivery model allows and promotes personal choice and control over their budgets. It also allows the participant or their authorized representative to serve as their employer over their employees. And we also understand that with this model, the participants need support in being the employer of their services. And so they have a team in place to help with those wraparound services. With the traditional model that is actually delivered by our community providers, these services are provided by DDA certified or licensed providers. These providers must go through Medicaid's enrollment process and then also be surveyed by the Office of Healthcare Quality to receive a license. The provider assumes all responsibilities as the employer of record, unlike the self-directed services delivery model. And then again, all of these providers are site-based. Well, the ones that are site-based are actually monitored by the Office of Healthcare Quality. So this slide, I'm not going to read it to you. It just, what we did was we are looking at our service enrollment by service delivery model. And so we're just sharing the growth that we've seen in both service delivery models by year, starting with fiscal year 2021 through fiscal year 2024. You'll note that with the service delivery model that is actually operated by our community providers, not a lot of growth there, but on the self-directed services side, we see unprecedented growth in that model. The next slide just speaks to those corresponding expenditures by fiscal year for both the traditional model as well as the self-directed model. And so I know that you all heard about the updates that the DDA just recently implemented to its self-directed services delivery model. And so we're here to talk about the goals of those updates and why we did that. So with stakeholder feedback, and as we have been examining our programs, we looked at the actual infrastructure and design of the self-directed services delivery model. And so the goals of our updates for the self-directed services delivery model basically is to get us to align with federal law and guidance, the CMS federally approved waiver authorities, our policies, as well as the Self-Direction Act of 2022. We understand, as we've been hearing from stakeholders, that there are concerns about more documentation. And we just want to note that these updates were and are necessary for us to make certain that we are providing appropriate funding for each individual and services. As a result of also listening to stakeholder feedback and responding to stakeholder feedback, we are reducing our processing times within the department as we review person-centered plans. And it's also to help the department respond to ongoing audits and concerns that have been raised in audits as well as investigations. With this additional information, as I said, it brings about some efficiencies for us, and we're able to reduce the extended back and forth that has been in place for some time. And that is my last slide here. Open for any questions in regard to the SDS service delivery model and our program updates.
Senator Reedy, you have a question?
Thank you, Madam Chair, and thank you for the presentation. As looking through it, obviously we all, probably all of us in this room, heard from constituents on the self-directed DDA issues. I know we were on a call with you all in, I guess it was late November or early November. So the changes have been fully implemented now, correct?
Yes.
Okay. You were correct in stating that there were concerns about documentations. That was one of the things that was brought up by people who contacted us. The time for getting things processed efficiently is also an issue. You say you're making progress on that. Can you elaborate? How are you all making progress?
Sure, absolutely. So in the past, we would request what we call clarification requests to get additional information to make an informed decision on person-centered plan requests. And in the past, there would be an extensive exchange between my team and the case manager as well as the participant in order to just get an approval through. By way of requesting this additional information, we're asking up front exactly what we need to make that informed decision. And so that's how we're gaining efficiencies in our processing times as we review the person-centered plan requests.
So if someone's already been getting these services, and I do see the statistic, of course, that it's growing in number of people who want to take this option. If people have been in this system for years, they undergo an annual redetermination?
Yes, that's a federal requirement.
Yes, and
So just to be clear, an annual redetermination related to Medicaid eligibility, and then the person-centered plan gets reviewed as well annually.
Okay. Does the person-centered plan does that all happen simultaneously, or?
Yes. So
Okay.
as the redetermination process is going through, the Medicaid administration is looking at the person's financial status, and
Right.
the DDA is looking at the technical and medical components. The technical component includes the person-centered planning process.
Is there a reason besides documentation holdups that you guys identified as a problem with? Because there were issues even before this, off and on, with people taking a long time, even before you guys were in your position. So did you guys review? Is documentation the main problem, or are there other issues that arise that keep people from getting approved?
So we do have some challenges with some of our partners, like the case management agencies. Sometimes that we need to make certain that the case management agencies are certain about our process and how the specific things they're asking for and how they're asking for what they're asking for. That's something that we identified in our process, which is why our clarification request process now includes the specific things that we're asking for to reduce that back and forth. So
Because before, part of that problem was that they would get everything that you thought they needed, but then the case management agency would be bringing up other issues.
correct.
And it
Could
was
be
hard.
the case manager or their support broker, for example.
Okay. What kind of oversight does the department have on the case management, on case managers?
They are our contracted entities, and so we are obligated to review exactly what they're doing on an ongoing basis. So the oversight is with the Maryland Department of Health as our contracted agents.
But even though you oversee them, they were telling you you're wrong about you guys should not be approving this because of X and Y, or am I not getting that right?
So I think one of the things that we've identified as part of the process is that the training at the contractual level wasn't as robust as it could have been. And so we did have case managers that were giving information that was conflicting with DDA policy, the same with the support brokers. And so DDA has now put in training and expectations for the support brokers, and we are now tightening up the training on our providers that provide the case management services.
Okay, and Madam Chair, I'm almost finished. I thank you for the time. Okay, that's good. Can you, just two more short questions. Can you when you say we've made progress, can you guys have like a way you quantify that as far as number of average days of wait, or?
So we do have service level agreements and expectations from the time that the person-centered plan comes in for what we think is I think it's 20
business
days.
days.
So that's what we're tracking internally now.
Okay.
How well are we doing to that 20-day mark?
And the
Okay.
last time that we ran our report, because we've been looking at this literally weekly, on average, the department is making a decision on plans within a little under 11 business days, according to our data. We
Okay.
do have outliers, that is an average, but
Understood. Yeah.
little under 11 business days.
The last thing, I guess, is maybe a question or just some information that I have is that I know part of the conversation was self-directed can start to spike costs. It's a concern. There is concern about possible maybe fraud or just people trying to get more out of the system than you can really take. All of that is, of course, we all agree is we want to be sure that's not happening. I did get some information that basically the self-directed in FY23, which is the soonest data we could get, there was an average of $175,000 in funding for self-directed individuals and $188,000 for individuals in traditional service. So if all, at that time, 2,777 participants that are in self-directed service went to a traditional service, it could be as much as $88 million more to the state. Now, that's a couple years old data, maybe even more now. That kind of runs counter to what we were hearing is that the concern about, or there seems to be, I think the community feels like there's this implication that we're more expensive, they're wanting to try to get us to keep our costs down, but they're actually, at least in the view of these numbers, saving money for the system.
Well, we'd like to get you more recent data, and a lot of things happen in 2023 to 2024, including moving from PCIS2, which is when we gave prospective payments to providers, and then drew down from that. We are now in LTSS, which is a fee-for-service model, so the providers bill, and we've seen an increased utilization on that side. But in addition, the Self-Direction Act of 2022 was implemented in 24, so some of the caps that were previously in place for self-direction are no longer in place. So, but we'd be happy to provide updated data for 2024.
I'd like that because I do recognize this is a couple years old. I appreciate that. And then in closing, just a statement, there are people who appealed and were upset about these issues. Some of them were new to the process, but there were a lot of folks that I talked to who have been doing self-direction for a long time or helping to facilitate self-direction. Does the department have like a stakeholder or some way of getting input back from longtime people who want to help with problem solving and troubleshooting? I recognize you can't talk to every single person for hours on end, but there are people that would be willing to be part of some sort of ad hoc committee that would help. Hey, we're running into this problem. Here's how we could help fix it. Is that something you guys are willing to look at? Do you have something like that already?
Yeah,
and that's
so
all, Madam Chair.
we actually have 2 platforms in place right now. So I meet monthly with the Self-Direction Advocacy Network, and then the DDA in October of 2024, we stood up a Medicaid Waiver Advisory Council that meets bi-monthly. That platform is designed to have a participant majority, meaning individuals with lived experiences and their family members get to have audience with us to talk about the system design. As a result of our meeting in October, the members on that stakeholder group asked to form a subcommittee to look at and do a thorough inspection of the waiver application. So we have a subcommittee also in play. And so the next meeting happened in December, and we got some really exciting information back from the members from the council, all very committed to helping us look at our waiver application as a whole to help us design the system. So we also are conducting community meetings now. So the meetings that my apologies, the months that the Waiver Advisory Council does not meet, we have community meetings. Both of these meetings are open to the public and accommodate a public comment period as well.
And are you finished now, Senator?
Yes, thank you.
Thank you. Senator Lamb?
Madam Chair. So a follow-up question on, thank you for the presentation. I believe there's about 3,700 constituents on waiting lists for Medicaid and also for our state plan waiver services. Given the kind of budget environment that we're in, multi-billion-dollar structural deficit, I think about $350 million that's overspent by DDA. In that context, how can we ensure the continuity and sustainability of services to meet all these Marylanders who have disabilities in kind of these out years? Because, we're concerned about the budget and, there's significant overruns from DDA just kind of looking at these cost numbers. What can you do to ensure continuity and sustainability here?
Want me to take it?
So thank you for that question, because to your point, we now have over 4,000 individuals who are awaiting services on our wait list. We are very happy about the investments that we're seeing in our FY 2026 budget in regard to being able to continue to support individuals who are transitioning youth coming out of the education system and so forth. Part of the reason why we're here is because we need to work together and making certain that our system is sustainable, to your point, in regard to the cost. And so we'll be working with our community partners to definitely address the concerns that you're raising in regard to individuals who need services but are not able to access services because of our spending growth. So we'll be working with our community partners to get through that.
Okay. I believe there's a waiting list equity fund that really has kind of grown over the years, in part because of insufficient kind of funds to be able to meet the demands there. What are the department's plans to try to address either limitations or help implement a plan to ensure that these funds are being utilized and that folks are being addressed off of the waiting list in a timely fashion?
So that's another excellent question. One of the things that we're proposing this year is to actually expend that waiting list fund so that we can put that money into services, and that requires a statutory change. And so the department is trying to work through that strategy to be able to fully exhaust or tap into that waitlist equity fund to provide services or redirect those funds to services.
And are you looking for a statutory change this session, or are you talking about next year?
This session.
This session. Okay. So there'll be a bill?
Yes.
Yeah. Okay. And then I guess finally, what's the percentage of waiver eligible participants that are served in community services who are enrolled in DDA waivers?
What's the
percentage of waiver eligible participants in community served in community services that are enrolled in DDA?
So are you
waivers?
saying inclusive of the people that are on the waiting list? Or
I
the
think
total
inclusive of
universe,
the people that are on the waiting list, yeah.
Can we get back to you to give you an accurate
Sure.
percentage? Yeah. Okay.
Okay, thank you.
Thank you, Senator. And Senator Mounts?
Thank you, Madam Chair. The new policies and procedures that were effective November 7th, 2024, can you surmise those for me?
Sure. So basically, what we did was we aligned this with our support broker training. My apologies, I got to get my notes here. We aligned this with our support broker training, and we looked at what we needed the support brokers to do to support participants in serving as employers of their services. So one of the things that we implemented is timesheet documentation, where the individuals would need to provide a checklist of the services that were performed during service to help us address some of our audit challenges with services provided and being paid for. Another thing we looked at was the wage exception process that we have in play. The wage exception process allows individuals to pay above the reasonable and customary standards to their direct employee. And so currently, the former way was participants attested to having the documentation needed to request a wage exception. We then said, please provide us the documentation that you're attesting to. So that was for our documentation standards. And then retrospective pay increases. So we are addressing participants requesting wage increases retrospectively without providing the documentation. So that was another documentation standard. Also looking at holiday pay. So we have participants who were requesting holiday pay that went above the reasonable and customary standards without any documentation as to why. And so the wage exception process played into there. So just more around documentation, things that participants used to attest to, we're now asking for the documentation to support the request.
Was this a series of changes, or was it one new package of changes?
It was a new package of updates.
Okay. And when you did that, was there a packet of paper that went out to say these are the new changes that are in place?
Yes, so we published our standards before implementation. We heard from our stakeholders who requested additional time, and so we gave a total of 30 days.
A total of 30. Would you be surprised if there were participants that felt that they weren't informed or were kind of blindsided by the changes?
Would I be surprised?
Yeah.
We have heard that some participants felt they were blindsided.
And there have been, I've received complaints about the changes, very critical of the changes, not just as the way the changes were done as far as, inclusion or informing the participants and things like that, but even to the extent of the way the program is supposed to function, and that some of the changes are undermining some of the best interests of the program. Have you received those complaints?
So I would say we've gotten the complaints. We've also heard from all of you as we monitor outreaches that we've gotten from the General Assembly as well as our own constituent services team. So we've gotten those complaints. But we've also gotten good feedback from some self-directed participants who say that the documentation is clearer and that the back and forth going between the care manager, the support broker, and clarification from the department has sped up the approval of their person-centered plan. Now, we've gotten more of the former than the latter as far as feedback, but we think it's just getting used to the new documentation.
I apologize, Madam Secretary, but I'm only allowed to ask a question to one witness.
Oh, sorry.
Senator, this is a briefing.
Oh, okay.
Feel free to ask.
It's the first time I got midway through, and I was like, uh-oh, I'm in trouble. I'm in trouble now. But to get back to the significance of this, it's the complaints and the concerns are very legitimate and sincere as they come to us, and I'm very I appreciate your answer. I think I understand a little bit more about what's going on. I don't have any more specific questions. I just wanted to make sure to share with you that we had received those, at the end of the day, you want an efficient, effective program, but you also want service, efficient, effective service, and any attention you can pay to those criticisms. They're concerning, and I'm sure you will, but I just want to take the opportunity to reiterate them. So thank you.
Appreciate it.
Thank you, Senator. I just have a quick question, Deputy Secretary. So for the providers that are paid, like the caregivers, what are their qualifications to be paid caregivers? Do they need CPR training? Do they need nursing training? What's the training required for the caregivers?
So for, at minimum, they are to have CPR and first aid and also be able to pass a criminal background check.
So even a family member would need to meet those qualifications.
Correct.
Are there salary scales based on their qualifications, or is it just whatever, as long as they meet those three things you just named, they can put in their own salary range?
Correct. So there is no range based on qualifications, and we definitely recognize that that's a challenge there because they get to set their wages, as you mentioned.
Does it need to be based on what caregivers are being paid in facilities, in licensed facilities, or is it the Wild Wild West?
It's based on how the participant sets their wages. It's not compared to what our community providers pay or what would be paid in an institution.
Thank you.
Sure.
I don't see any other questions on the self-directed services. Next, we're going to do the Medicaid update. Dr. Scott, you'll stay.
And Dr. Ryan Moran. Yep.
Thank you.
So I'm going to turn it right over to Dr. Moran.
Hi, members of the committee, Chair Beidel. Congratulations, Vice Chair, on your new post, and it's good to see the members of the committee. The Secretary and I, per the committee's request, really wanted to talk about the current state of Maryland Medicaid. Is there a clicker here or someone? Oh, that doesn't? Okay. Make sure we're at the right slides. The current state of the Medicaid program, and I want to start by saying that over the course of the last couple of years for Medicaid, this has truly been a historic and an unprecedented time for the program. I would argue that it hails right in comparison with the Affordable Care Act and also since the inception of Medicaid and Medicare in the 60s. But it's also important, I think, to understand this in the context of why that is and what's happening nationally. So among those particular drivers of that context is, first of all, as I think you know, we've briefed this committee before, but during the public health emergency, Medicaid coverage was continuous. So individuals stayed on Medicaid coverage from 2020 through the start of 2023. And with that, the federal government provided states with enhanced federal match support for that over the course of 3 fiscal years. That totaled approximately $1.7 billion over the course of that time while people remained continuously enrolled. That phased down and ended in the previous fiscal year. Secondly, one of the things that made it the most historic as part of the year was we started the work of redeterminations again. So during COVID, our enrollment grew from 1.4 to the beginning of 2020 to about 1.8 million at the start of the redeterminations process. Again, states had the option and the latitude to choose whether 6 months or 12 months. Maryland chose a 12-month time period. Redeterminations took place on a monthly basis over cohorts. That process concluded in terms of getting everybody who was eligible for a redetermination through in April, May of 2024, so just a short 6 months ago. In that process, we were very proud. The Maryland Department of Health and the Medicaid Administration Program was a leader in coverage retention, meaning that when you compared us to other states, we used a lot of flexibilities that supported the process of individuals going back through the system in terms of the renewal of their eligibility. Also, over the last couple of years, we have seen an increase on state Medicaid programs in terms of federal mandates. Things to support coverage retention that were passed as part of federal statute included continuous eligibility for children for a full 12 months, regardless of the change in children's income over a 12-month period in their household. Children must remain covered for a full 12-month period. We've also seen changes at the FDA level in terms of drugs for certain indications related to obesity, specifically sleep apnea and others. We also, starting here in January, are working very closely with our Department of Juvenile Services team on coverage of justice-involved youth. And then as you read your own newspapers, you will find very strong utilization and cost of service trends that have existed in terms of increased clinical acuity of individuals accessing healthcare, largely driven, obviously, from the pent-up demand from the public health emergency. On the second slide, I think it's important in terms of highlighting that, yes, it's been an unprecedented 18 to 2 years for the program, but I'll just mention, and we've said this before, but Medicaid is one of the most important safeguards of healthcare coverage for 25% of Marylanders in this state. including over 700,000 children. Also, any of the research that you look at will tell you that it is one of the most effective, if not the most important and effective anti-poverty tools, particularly for children. 96% of the Maryland Medicaid's budget goes directly to care and services, and we have nearly doubled the number of enrolled providers that we have across the state in the last decade, moving from about 60,000 to currently at around 117,000. On the next slide, I'll just mention the chair wanted an update in terms of the recent situation that we had with Kaiser in terms of contract negotiations related to Health Choice Managed Care participation in the calendar year of 2025. This slide covers that those issues in those contract negotiations this fall and over the course of the past year, 18 months, really related around Kaiser's financial reporting. Just for some context, as we look at the 9 MCOs that we have and also Kaiser, historically, when you looked at Kaiser, they have a higher cost structure than when you look at it and compared to our other managed care organizations. And so that meant when we looked at their financial filings that in 2022, their expenses actually were no longer a cost outlier when you compared them to other MCOs. So for the purposes of rate setting, that meant that Kaiser needed to be evaluated amongst all other MCOs. So in the fall of 2023, we engaged Kaiser in signing a contract amendment for years 22, 23, 24 that would outline specific expectations to receive financial data from them in order to evaluate them amongst all other MCOs. We have worked over the course of the fall in contract negotiations, as well as with our actuarial rate setting firm, Myers and Stauffer, to come to an agreement of what is needed for calendar year 25 and moving forward. And the calendar year 25 contract, specifically with Kaiser, mentions those financial reporting requirements. And we're currently reviewing financial reporting documents that were submitted earlier this month from Kaiser, and I would say we take very seriously our role to ensure that all of our MCOs meet federal and state reporting requirements. And then on the next slide, I just wanted to highlight that in the terms of all of our other managed care contracts that we executed with all 9 MCOs as we start the calendar year, guided by the values that we hold and focusing and ensuring that healthcare investments prioritize healthcare equity and improves health outcomes for all Marylanders enrolled in the Medicaid program. We have increased the bar of accountability and responsibility of our MCOs, and I just want to highlight a couple of those. First is all MCOs have to retain NCQA health equity accreditation. That includes a series of best practices from NCQA. If you want to participate as a Maryland managed care organization, you have to achieve that accreditation. Second, we've implemented targeted staffing requirements requiring plans to have key C-suite positions. Think of this as CEO, CFO, CIO individuals, and that we're making sure that they are investing those roles into the state of Maryland. Then there are a number of other things where we're asking MCOs to do a better job of coordination of care. That includes justice-involved youth. That includes screening individuals for social determinants of health and navigating them to services in the community, things like housing, transportation, education, support, et cetera. And also maternal child health, which remains a priority for us in terms of the work that we do in this particular space. Also, I will say that we are also increasing the expectations that we have for MCOs related to the quality of care, coordination, and services that they are supporting their own individual participants in order to meet our goals, which is to drive population health improvement. With that, I'll wrap up, and I always like to close these briefings by thanking the 700 people who work day in and day out in public service and Medicaid. They are some amazing folks, and credit to all this particular work goes to them.
Thank you, Dr. Moran. Dr. Lamb, you have a question?
Sure. Thank you. Thanks for that presentation. You touched on redeterminations earlier, but you didn't have a percentage of how many, any figure on how many folks were pushed off of Medicaid that were not redetermined. Do you have any final numbers on that?
Yes. So we were one of the top 5, 6 states. 70% of individuals that went through the process retained their eligibility after the first full year.
Okay, so about a quarter didn't. What does that come out to? How many Marylanders potentially lost
So
coverage?
currently, right now, so at the start of the public health emergency, when we started unwinding, we're at 1.8 million. Right now, we're around 1.6. And there's also, and I know we have talked about this, there's also assumption that maybe those individuals don't have coverage. That may not necessarily be true. We set up automatic pathways for them to go to the health insurance exchange in order to receive subsidies. We also know that individuals lost employment during COVID, so there's a factor of individuals regaining employment, and now they have coverage with their employer. That number in terms of employer coverage for individuals that have gone through the process is really hard to obtain. There's really not a great source for that information.
Okay. I have a separate question on the transition from Optum to Carelon. I know that's not part of this, but under the broader umbrella of healthcare financing, because I've been hearing from some providers that are still waiting on payments from, well, I guess it was previously Optum, now transitioned to Carelon. And there are some programs that are at risk. These are, I think, mostly behavioral health providers that are at risk of closing the doors because they still haven't received payment from mid-December. And, you know, Optum didn't provide any explanation. It seemed like there was a period of time in the last couple of weeks of the contract that Optum was not responsive anymore. And so I've been hearing an earful from a lot of providers. There's still, you know, there's a provider in Howard County and Baltimore County that still are pending payments and at risk of closing their doors. Happy to forward their information along and see if we could address that. But what's the broader picture of where this is at right now?
So the broader picture is the system is working and it's paying claims. We did have many provider forums leading up to January 1st, and providers had to get a new provider ID with Carelon, and so they could access their system. And so at the time of January 1st, we only had less than 70% of all providers had gotten that provider ID. So that was one of the things that was holding up those payments. We have been working with Carelon, and they've gotten additional resources in their call center to work with providers to get them enrolled in the Carelon system. We've also relaxed authorizations for the month of January, so that's not the thing that's holding up their payments. Based on our weekly check run, we're exceeding 70% of what we would normally pay on a weekly basis, and for those providers that haven't gone in the system, like I said, we're still working on with them. We have gotten some provider complaints that the number didn't work or they couldn't get through the call center, and there has been an increase in call center activities with longer than expected wait time, but we're working with Carelon to address those concerns, and they are bringing additional resources. For the providers that have reached out to you directly, if you can send them our way, we are working one by one and walking providers through the system the first time if it's not been clear, so they can get their number and they can get paid. The other thing we're encouraging is a fair number of providers are on paper-based checks, and with the holiday, former President Jimmy Carter and some of the other holidays after the new year, that did delay the checks going out. But to our knowledge, as we check the people that say they haven't gotten their checks, they've since gotten their checks. And like I said, we are tracking weekly check runs.
What about any concerns of Optum not having paid providers during the period that Optum was still the, no?
We
those
haven't
have all
gotten
been
that
addressed.
as a complaint, and all the files moved over to Carelon prior to the 1/1 start date.
Yeah, I'll just mention that the claim submission, the cutover to Carelon, started on the 22nd of December. So at that point, then all claims moved over to Carelon and using the authorization data and claims information that we had for Carelon.
So the things that Optum should have processed and
Correct.
paid for
Should have been in by that
should
date.
have been done?
Yep.
Okay,
by
and if
that
there
date.
are concerns from providers that we're hearing, just
We are happy to
follow up with
address individual providers if you want to send them their way to look into the issue.
you. Okay. Okay. We'll follow up then with certain providers. Thank you.
Thank you, Senator. Senator Hershey?
Thank you, Madam Chair. Deputy Secretary Moran, you had mentioned on slide 12 that you were a national leader in coverage retention. MDH adopted 15 federal flexibilities in underwriting, which bolstered enrollment retention for eligible people significantly and resulted in cost exceeding original budget projections. Obviously, we're in very dire fiscal condition in the state of Maryland. Was it a goal of the department to retain as many people as possible?
The goal of the department was for every single individual in the state of Maryland that remained eligible for Medicaid, that they retain their coverage.
And what were those then determining factors? Because there's conversations out there right now that's saying that families making $80,000 a year are getting Medicaid services. So what are the determining factors?
So
for
we
that?
follow, it depends, right, in terms of who you are, what your medical, financial, technical criteria is. Generally, if you're qualifying for Medicaid solely on the basis of income, right, for a household of one, that's about $21,000 up to 138% of the federal poverty level for a full year. And if you're a family of four, that is $41,000 at that particular range. But again, it depends based on your eligibility coverage group. Pregnancy, individuals who are pregnant have higher coverage categories. We cover children up to 300% of the federal poverty level. And then if you're applying for one of our waiver services, there are other review criteria that come into play.
So again, going back, there was an underestimate from Department of Health on how many people would be retained, and is that what caused the budget?
What I would say, Senator Hershey, is that if you look across the country in terms of all states, there was a high level of uncertainty and unpredictability in terms of going through this process again of where the number of individuals who would retain their coverage be. What we saw during the course of the redeterminations period and where we landed, those numbers were high, the projections of enrollment were higher than the projections that were originally budgeted. That also, if you talk to my colleagues from across the state, from each of the coasts, you will find that also to be the case just based on the uncertainty of going through this process for the first time again.
Okay. You mentioned, if possible, if somebody was not eligible, that you would push them to the health benefit exchange, right?
So if individuals do not meet income criteria, we have set up protocols where individuals are referred to receive coverage on the exchange, yes.
Is there a follow-up with those individuals to see if they did get on the exchange and obtain insurance?
We did track data on individuals who moved over to the state health insurance exchange,
What
yes.
did that rate look like? Do you recall?
I don't have it off the top of my head, but I'm happy to take it and get back to you.
All right, I appreciate it. Okay,
Yep.
thank you
Thanks,
very
Senator
much.
Hershey.
Thanks.
Thank you, Senator. Senator Ellis.
Yeah, thank you, Madam Chair. Thank you, Dr. Scott, Dr. Moran, for your briefing today. I have a question as far as the payment structure with Medicaid services. So Medicaid is a joint program between federal and state, 50-50, right? So if someone comes in, receive a service, who pays first? Who pays that provider?
So
Or is it-
the front door ends to be you're coming if you're an eligible Medicaid participant, you receive service, the claim is paid based on the rate, if you will. And then so on our reporting, then when we report that to CMS on our financial reporting, that's the Fed and the state split that we document on that. And when we draw down the federal match based on tracking that claims information, if you will.
Right. So with the federal match, do we account for all the services being reimbursed from the federal government? Or is there sometimes where we don't get reimbursed for that federal match?
So you have to, so in the Medicaid program, there are required benefits that state Medicaid programs have to have. Then there are additional benefits. For all benefits and coverage services, we have to have the appropriate authority for those. So either CMS has to approve those, as if you will, to answer your question, in order to get that federal match. That's either documented in a waiver services plan or within our state plan amendment, yes.
Yeah, but okay, I guess, assuming all the services are pretty much authorized and approved, is there any times when the federal government does not reimburse Maryland for that 50%?
No, although I will say that the federal government can say that certain federal matching dollars are not eligible for services. The best example that's coming to my mind includes the Hyde Amendment, where you can only have certain services related to abortion services that are paid. But the federal government would have that latitude. If it's approved by the federal government through one of our authorities, then we are eligible to receive the federal match unless there are changes federally.
Yeah. So percentage-wise, what percentage of, say, charges we have to pay 100% because the federal government said we're not going to pay for services? Do you have that number?
Oh, it's so
Yes?
small because all of our program receives the match. So
there's a
abortion is the only example I'm thinking of currently.
But there's a small percentage, but
And even our work around undocumented individuals and healthy babies, we still receive federal match on those services as well.
okay, great.
Yeah.
Thank you. Okay. Thank you, Madam Chair.
Thank you, Senator. I see no other questions on this topic. Dr. Moran, thank you for your work. It's always a pleasure to work with you.
Thank you.
Dr. Rara Scott, let's bring up Dr. Kalyanarama, and we're going to do the Office of Healthcare Equality update.
Yes, I'd also like to bring up Tia Witherspoon, who's the new Executive Director for the Office of Healthcare Quality.
Oh, thank you, Ms. Witherspoon.
All right. Good afternoon, Chair Bidle, Vice Chair Hayes. Good to see all of the members of the committee. I'm Nilesh Kalyanaraman, I'm the Deputy Secretary for Public Health here at the Maryland Department of Health, and I have with me Tia Witherspoon, who is now about 3 months into being the Executive Director of the Office of Healthcare Quality. Do I have the? There we go. Excuse me 1 second while I get this. I'm going the wrong way. Fantastic. There we go. All right. So here to talk about the Office of Healthcare Quality. I just provide a little bit of background before we talk about where we are with the long-term care oversight. As of July 1st, OHCQ oversaw over 22,000 providers in 47 different healthcare industries, and this reflects a 5.5% increase in the number of providers that we oversee at OHCQ. And for the second year in a row, the growth was primarily in a few areas: residential service agencies, healthcare staffing agencies, sites serving individuals with developmental disabilities, and you heard a little bit about that from Deputy Secretary Hutchinson, and then, of course, our clinical laboratories. And overall, OHCQ has experienced an 18% growth rate in the total number of licensed providers over the past 3 years. Specifically on the long-term care unit's priorities, it is to address the nursing home inspection backlog. We have talked about that in this committee. I'm happy to note that we're trending in the right direction. We haven't gotten there yet, but we are seeing increases in our inspection speed, and we're seeing a decrease in the backlog. So from FY22 to 24, we've seen a 48% increase in completed nursing home inspections. But more importantly, in the first 5 months of FY25, we've seen an increase of about 160%. Our current backlog of surveys is down from 172 at its peak at the end of 2023 to 127. No, we're not where we need to be yet, but we're headed in the right direction, and we've got annual full surveys that are up to date of about 95. And specifically, we've done 51 surveys in the first 5 months of this fiscal year. So the second piece of that is our intakes, which are complaints, as we talk about them. So those are complaints that we get externally, and also any facility reported incidents from the facilities themselves. For background, the average time it takes is about 8 to 10 hours to investigate each one of these intakes. Similar to the annual surveys, we are seeing that we are trending in the right direction as well on this. From FY22 to 24, we saw a 45% increase in completed investigations for intakes, and in the first 5 months of FY25, we've seen a 72% increase in that speed. Currently, we have pending intakes, and this is as of the end of November. We have about 5,900 intakes, which is substantially lower than our peak of 9,500 in July 1st of 2023. Just for background, we've had an increasing number of intakes over the course of the past 5 years per year, and then in FY24 we had approximately 4,000 intakes. So we not only moved through what we got, but we're also clearing out the backlog. And just in the first 5 months of FY25, we've done 2,000 complaints and are continuing that activity. We've got we've got a number of initiatives to address this backlog. Key amongst them is actually increasing our number of nurse surveyors and training them up. In FY24, OHCQ filled 5 of these nurse surveyor positions, new nurse surveyor positions, and in FY25 we were given 13 positions, 12 for surveyors, 1 for a coordinator, and all 13 of those positions have been filled. And thank this committee for helping us get those positions. So currently we have 62 surveyors, 17 of them are in training. So important to note that in the past at least 5 years, we have not gotten a single surveyor who we hired who had the certification necessary to complete the surveys. That is federal. That's a federal SMQT certification. That takes anywhere from 6 to 12 months of training for those surveyors to get certified so that they can independently do those surveys. So we've got 17 in training right now. 2 positions are awaiting start dates, 2 vacancies. So we've been working really aggressively to, if there's a vacancy, fill that position. We've also had PIN conversions, and one of the bigger things that has helped us is the nursing salary 2-grade increase that went into place over a year ago. One point that I want to mention here is that one of the reasons that we've been successful is our training program for our nurse surveyors. We have a trainer who is really focused on just the LTC surveyor training process. He has brought down that time of certification for our new surveyors. He's been working on having monthly refreshers, and he's been working with our surveyors to improve their practice even after they become certified. And so that's been a key part of this, and actually it's been so successful. The secretary has taken his work and is applying it elsewhere within the department. Yes, there we go. We've also got CMS is also providing nurse surveyors and subcontractors. We've had this conversation with CMS for a long time. They acknowledge that there hasn't actually been any increase in federal funding since 2014 for LTC nurse surveyor activities. And so they've been providing some certified nurse surveyors on contract to work through annual surveys here in Maryland and a number of other states as well that are experiencing backlogs. It is as they are able to provide that service. So far, they've completed 16 surveys. They've got 1 in progress, and they've plan to complete additional ones, and we're hoping that they're able to do more to support us. The other piece of this is that we've contracted with, we, MDH, have a contract with surveyors. We have two companies that we're contracted with to provide nurse surveyors who are already certified to provide contract services to clear out intakes in advance of our teams going in to do the annual survey. Just to demonstrate what that help looks like, when our teams go in and we have to clear through the intakes and the annual survey, it takes sometimes a month or even more to be able to go through that. With those intakes cleared out, it takes anywhere from 1 to 2 weeks, depending on the size, to conduct that annual survey, which is much more in line with how we used to operate. So those are really 2 key pieces of our ability to move through the backlog. And once we get through that and those new nurse surveyors are certified, that'll allow us to also increase our speed of our survey activity. We estimate that it's going to take 2 to 3 years to catch up, and this completion rate is impacted by a couple of things. I mentioned the time it takes for surveyors to get certified, the severity of the investigations. We do have to do revisits, so when we go out during an annual survey, if revisits are required, and it depends on the findings that are there, we do have to send a team out again to those facilities. Obviously, the CMS contractors are a limiting rate. If we get more, that'll help us move through the backlog. And we were hopeful to get more surveyors from our contractors. We had the budget to hire up to 17, but we've only been able to find anywhere from 5 to 8 at any given time. But we continue to lean on those contractors as we've learned. Other states are doing the exact same thing that we are, and so we're fighting for a limited pool of certified surveyors at the federal level. We are, of course, working on our staffing plan for FY25 and beyond. So that's the update of where we are and what we're projecting. As I said, 2 to 3 years, but we're also already almost a year into this plan. So we are, I think, on a good trajectory. As I mentioned, we're not there yet, but we aim to be. Thank you.
Thank you, Dr. Kaye. I have a question for Executive Director Witherspoon. Thank you. And welcome to Maryland. We're very happy to have you here. In the surveys that you're catching up on, do you know how many of those were transfers from privately owned to private equity?
I can give you. So we have actually, since we'll get you the exact number, but since the beginning of 2024, we have done every change in ownership. We have done a survey of every one of those.
The new ones?
Yes, everyone that's, yes, correct.
But we didn't go back to 21 when the bill was passed and nothing was done till 24.
We did not go back. That'll be captured in terms of an annual survey. It won't capture the change in ownership at that time, but we are committed to going forward.
When you can, Dr. Kaye, I'd like to see the violations that you found in those facilities that are private equity, please.
We'll get that to you.
Thank you. Do I have any other questions? Senator Kramer.
Thank you for that, Madam Chair. Doctor, I'm glad to hear that we are trending in the right direction in ensuring that we are providing some bare minimal protections to our most vulnerable in our communities. That's good to hear. But I have the impression we have quite a long ways to go, including your representation that it'll be at least 2 to 3 years before we are providing those protections to all of our most vulnerable residents here in the state. If I recall, the last time you and I had a conversation about this, and that was maybe 3 months ago, I believe that in 2023, the state of Maryland was tied for dead last in the country with the great state of Kentucky for failures to be doing these nursing home inspections. Then in 2024, we moved out of last place. That's a good thing. We were tied for second to last place with the great state of Alabama for the most failures to be doing nursing home inspections. The only reason we moved out of a tie for dead last was evidently Kentucky continued to fail even worse. So we moved up to a tie with Alabama. I have been expressing concern about this and the fact that Montgomery County government, which up until 2019 was taking full responsibility for doing these inspections on behalf of the state, it stopped. The state has refused to grant that authority to Montgomery County since. When last you and I spoke a couple of months ago, I had an opportunity to read the contract that exists between the state of Maryland and the federal government, because these inspections are a federal responsibility. The federal governments give that authority to the states and in turn provide the states with funding to do these inspections. So I had asked, what funding has the department received specifically for doing the nursing home surveys? I was provided that. I asked for other things that have never been received. What I note is that in 2020, the state received $3 million. In 2021, $4 million from the feds for doing these inspections. In 2022, $3.4 million, 23, $3.5 million, and in 2024, $3.7 million. Now, you have just received in the last day from me a request to share with this committee how those dollars were spent each year and how many inspections were done with those dollars. And the reason I say that is unless Montgomery County is an outlier, there was approximately a 4-year span between that 2019 to 2023 or so, maybe 24, when of, I believe, our 36 nursing homes that are to be inspected on an annual basis, there was a total of 5 inspections in all that time of Montgomery County nursing homes. Now, maybe they have been particularly neglected and the rest of the state is receiving all those annual inspections, and that money, averaging $3.5 million a year, is being put to good use. But I would have to ask that if, on average, Montgomery County over a 4-year period was receiving 1 nursing home inspection a year, how was the $3.5 million being utilized if it was just that 1 inspection? Your statistics imply that things are really happening. However, if you take a look at it, at fiscal year 2022 through fiscal year 24, there was a 48% increase in nursing home inspections. Well, in Montgomery County, that would actually translate from 1 inspection of our 36 nursing homes to 2 inspections of the nursing homes in Montgomery County. So we've got a statistic, but it doesn't really, I think in my mind, reflect the reality of how we continue to fail the most vulnerable residents in the state of Maryland. Now, I also note, and I asked you this question 3 months ago, you sent a letter over your signature indicating that one of the problems of giving Montgomery County this authority again was that if Montgomery County started to do more, and colleagues, there are multiple tiers of inspections. Tier 1 is the most basic. That is, the department announces they're coming in, and the nursing home has the opportunity to prepare for that inspection. You put in writing that if Montgomery County moved up tier levels, for instance, unannounced inspections, that's a different tier, that they would violate federal regulations and subject the state to fines. I asked you at the time to please document that information. The Montgomery County attorney has taken a look at the contract and has not found that to be the case. So I specifically asked you to document your assertion. And if you had a Maryland state attorney's, AG's opinion on that. I've never received anything. Nothing to date at all from you. The county also asked and has not received anything. So I would certainly question that why would the federal government punish anyone for doing a thorough job of inspecting nursing homes, that somehow if Montgomery County got on the ball and started doing tier 2, tier 3 inspections, the state would be subject to a fine for doing a thorough job of protecting the residents. So these are concerns I have been sharing with you all for quite some time. They have not been addressed. To date, there still has been no agreement to allow Montgomery County to do these inspections, but I will say, I heard from the county that you all indicated you would be willing to consider allowing them to do this again. However, the statement was that you all would not share at all in the cost of the county doing so. And that the logic was, why would you be giving money to Montgomery County? That's not fair. Well, of $3.5 million that you're receiving annually from the federal government, I would assume some of that has to be to do inspections in Montgomery County. So if Montgomery County is taking on the full liability for doing this, would it not be appropriate? And by the way, my personal opinion is that the state should pay 100% of their contracted responsibility with the federal governments, pass those funds on to reflect Montgomery County's lifting the burden off the state, but the county has said they're willing to pay for 50% themselves. They'll eat half of the state responsibility. But the state's reply has been, no, we're giving you nothing other than possibly the authority. So here we are, doctor, and a year has passed since we had a conversation about this, and we're right in the same place we were. And I would ask you, please share with me the logic. And by the way, you just stated that you're having problems getting enough. You've got it in the budget, but you're having problems finding surveyors. Montgomery County is willing to do that. You won't have to find surveyors to inspect Montgomery County. In fact, if the legislation we have this session is passed, all of those jurisdictions who are very concerned about protecting their most vulnerable will be granted the opportunity to do what we've been asking to restore in Montgomery County, which lasted for 10 years. So please share with me where we are on that and why the state would refuse to offer any funds to Montgomery County to fulfill the state's contractual responsibilities with the federal government.
Happy to, Senator Kramer. There were a number of points in there, so I'll try to hit them all. And if I don't, just please let me know what I didn't get to. So I want to start with where we are with Montgomery County. So in the first 6 months of this fiscal year, we've completed 9 annual surveys. In facilities in Montgomery County, 2 are underway, and many more are coming. As we've talked about, we can't announce schedules in advance, but many more are coming for those facilities in
May I ask
Montgomery.
what tier level those inspections are?
Those are the first tier.
All just first tier?
Yes.
Thank you.
So just to share that data for Montgomery County, at least specifically, that's where we are in that survey. So that's more than a third of the facilities, or a third of the facilities in the county in the past 6 months. And so we are making progress on that front. The second question around tiers and the language, I've shared multiple times the CMS language around tiers and essentially the criteria for what it takes to move ahead. For the benefit of the committee, there are 4 tiers, and the CMS guidelines or rules are that the state, once the state is up to date in that tier, it can then move to the next tier. And for example, that means annual surveys need to be completed, and then the next tier is then you start doing annual surveys during the evenings or weekends. Then you start doing non-Medicare facilities, and I'm blanking on the 4th. But essentially, there's a progression that says as you complete more and more surveys, you get to expand the scope of what your survey activity is, right? The CMS guidelines, I've shared that multiple times.
And while we're on just that one topic, if I may, Doctor, those CMS guidelines have been reviewed by Montgomery County's attorney, and they have indicated there is nothing that they see that reflects your assertion that the federal government will fine the state if Montgomery County is doing Tier 2 or Tier 3 inspections and the rest of the state is still just at Tier 1. So I asked you for a legal advice from the Attorney General's office validating your assertion, because I've read it. I don't see anything in there, but I went to the county attorney's office.
And we consulted with our CMS partners who oversee our work, and actually when we do annual surveys, those are done in concert with our CMS partners, because this is a delegated function from CMS. And so when we are determining which ones are the next ones, our team runs that list, I believe it's weekly at this point, with CMS to determine, okay, what are the next facilities that are up, right? And so what you're asking for, I will say this, what you're asking for is for me to be able to reiterate what is our expectation from our CMS team that we work with and what is in regulations. And I can only tell you what we are bound by the CMS team that oversees our work.
Do you have documentation from the CMS team that would validate your assertion that the federal government will be fining the state of Maryland if Montgomery County does Tier 2 and there are still Tier 1 inspections elsewhere in the state? I am asking for more than just your opinion on the matter, sir. I am asking for something that is legally binding, and I have not received that documentation. And that's why, to be honest with you, Doctor, it defies logic that the federal government would penalize the state of Maryland because some nursing homes are getting more thorough inspections while others are being caught up. It defies logic.
Senator, I'm going to
Yes,
ask
ma'am.
that we take this offline. Council's happy to meet with you and Dr. Kaye. I'll certainly join if I can. This is very complicated, and I think that Dr. Kaye, we need to get, these are important, and we'll set up a meeting.
Sounds good.
Thank you. Do I have any other questions for the Office of Healthcare Quality, this update? No other questions. Thank you very much, Dr. Kaye. And
Thank you, Madam Chair.
Ms. Witherspoon, thank you. Next, we're going to go to our 4th subject, the Maryland Department of Health Staffing and Vacancy Rate. And Dr. Rivera-Scott, you're going to address that, right?
Thank you, Madam Chair. So this is an update of where we are on the Maryland Department of Health vacancy. In front of you is a chart on our merit vacancy rates as of December 31st of 2024. We broke it down a few different ways. So when you look at all positions, our vacancy factor is 18%. If we break it down without the new positions, as many of you know, we had a number of new security positions that were authorized for this fiscal year that we're in the middle of hiring. But without those new positions, it's 10.7. If we do with the new positions, without the facilities, it's 17.9, and without the new positions and without the facilities, 11.9. So without the facilities would be MDH proper, 201 Preston Street, OHCQ, things like that. So I did want to give it a few different ways depending on who's asking for the information and what the total picture looks like. This is the breakdown. Again, just another way to do it with the pie charts. Looking at the blue and the orange, those are the non-facility ongoing positions, and then the gray and the yellow are the facilities. And you can see 28% of those new positions, the majority of those are those new security pins that we received. Whoops. So this is our employee retention data and metrics. So for total employees, we have 8,307. In the last year, you have the terminations, voluntary or involuntary. So our retention rate from 1/1/24 to 1/10/25 was 93%. We went down one further and broke that down from headquarters to facilities. And you can see that the facility retention rate is lower. Again, that's something that we're actively working on. I do want to note that this does not include contractual employees, and it's not inclusive of our employees at the local health departments. And these are some of the retention resources that we have today that we're actually working on. We have supervisory leadership and development programs. We have work study programs, workday learning courses. We have Percipio as a platform that we use for supplemental training programs. Financially, we have had annual pay enhancements with COLAs and with in-grade increases, two-step increases in last year's budget. We have longevity increases with additional steps, and then we certainly have annual salary review processes for certain positions. We've actually used this ASR process more in our facilities, so as we try and benchmark with other facilities that we're competing for psychiatrists, for nurses, for social workers, psychologists, et cetera. And then we certainly check in our employees regularly and support our employees' mental health. And we have our employee assistance program, our 988 suicide and crisis lifeline, and My MD Cares, which not only supports our employees, but our employees' families. And EAP, or My MD Cares is anonymous. EAP works like other EAP programs. So that's an update on where we are with our vacancy factor and the supports that are now in place or have been in place for MDH employees.
I see a question from Senator Mounts.
Thank you, Madam Chair. I'm not sure if this fits in because it's a general briefing, but we're going to talk about vacancy and retention, but something else that affecting the overall function of the department. Secretary Scott, the Surveillance and Utilization Review Subsystem, SURS, are you familiar with that?
I'm not.
Okay. That's required by the federal government, and it's an accounting of expenditures and things like that. It's a contract that's issued by the Department of Health. The Department of Health has received repeated unsatisfactory ratings or audits from the Department of Legislative Services focusing on that contract. And I guess so this would not be the time to bring this up because I don't want to, I'd like to maybe follow up with you in another conversation.
Yeah, I'm actually, now that you're saying it from OLA, I'm familiar with it and was happy to discuss the findings and the work that's underway to address those repeat findings.
Yeah, and the manner in which that contract is sort of being carried out because it's been a problem and then it was just renewed. And I had some questions about that. So if we could do that, I'd appreciate that.
We'll get some time on your calendar.
Thank you.
Sure.
Thank you, Senator. Senator Ellis.
Thank you, Madam Chair. Really quick question, Dr. Scott. In your...
Want me to go back?
No, just a quick question. You talked about headquarters and facilities of personnel. So what would you consider as a facility
So we have 11 healthcare facilities. We have 5 forensic facilities for adults. One's a maximum security, which is Clifton T. Perkins. We have 2 nursing homes. We have 2 facilities for persons with intellectual and developmental disabilities. And we also have 2 regional institutes for children and adolescents, which are almost like a residential treatment center that has a school for children with severe emotional disturbance. So we run 11 healthcare facilities, inclusive of psychiatric hospitals.
So when you say facilities, that's, places that our citizens receive services.
Correct. And those facilities are mostly clinicians, so psychiatrists, social work, psychologists. For the RICAs, we also have teachers because we provide education for the children that are getting their care there, dietary, security, so the typical kinds of employees that would work in a hospital setting.
Great, thank you.
Sure.
Thank you, Madam Chair.
Thank you, Senator. And Senator Lamb?
Thank you, Madam Chair. A question about, I guess, hiring and personnel for local health departments, which kind of broadly wraps up under MDH. Been, serve on the Public Health Commission, and one of the things that has come forward is that a lot of these local health departments have had a hard time filling their positions because it's routed back through the department's HR and hiring practices. And because these are local health departments, oftentimes when they're rerouted through MDH at the departmental level, they're reclassified or recategorized in a way that makes them harder to fill for these local health departments because, I think because they're considered local positions, they're downgraded, so to speak, from in comparison to the state level or MDH positions that are being filled. And it's led to a more difficult time for these local health departments to actually fill these positions because of, from their perspective, a lack of understanding at the departmental level, the positions and the value that they bring. Any thoughts on how to address this problem? Because it is a problem that the Public Health Commission has been talking about actively.
So, I would welcome examples. We've heard that a few times. And for instance, one of the things that we heard was the time from the time the position was posted to the time that an offer was being extended. And when we did a deep dive of when we looked at where the positions were sitting, most of the time was actually at the local level. It was by the time they went through the list, by the time they started their interview process, it was a pretty significant amount of time that was taken. I can't tell you about the positions themselves because we work with job classifications that are based on DBM criteria, so I'm not familiar with downgrading of any positions at the local level. If you're in a nurse position, a community nurse position, arguably that's a standard position, and those decisions get made locally. I'd be happy to look at the issues that you've heard from the local health departments and which local health departments. I will say, especially for the clinical workforce, the local health departments are competing with their larger healthcare delivery systems. So it could be their hospital, their federally qualified health center. And so sometimes they do want to come in higher than what the midpoint is. But even at the midpoint, oftentimes the local delivery system is paying more than what we pay in our salary range for those positions. But happy to look at concrete examples if you could provide those concrete examples. We've heard this a couple times and we've looked at the time that it's taking, and it's not taking any longer for a local health department. And I'm not familiar with downgrading any positions based on at least the kind of position that they're asking to be filled.
Okay, well, we're happy to follow up because this
Sure.
has come up through the commission. I think, it's a concern that multiple health departments have had. They've been directed to not speak to us about things that they want to bring up. So it's come through the commission route, and happy to have a further conversation about that because I think it's a real problem for them to be able to fill these local positions simply because of the structure they fall under. They're technically state employees. And so maybe downgrading is not the right word, but somehow they're managed in a way or posted in a way that makes them less competitive to MDH positions, and that sets the local health departments at a disadvantage.
Okay, well, we can certainly address that if that is in fact the case. So happy to have a discussion offline, and if you have any examples or any local health officers are willing to speak to myself and Dr. K, we can certainly look into that and address it.
Okay, because they've been told not to speak to us. That's what I've heard.
We have an open door policy and very
That
transparent.
it should go through the ledge office, that any contacts with us as legislators need to go through the ledge office, not directly from the local health officers.
Well, I just don't know why the local health department wouldn't just reach out to Dr. K and myself to work on an HR issue. So I'm not familiar with the issue that you're describing.
Okay. Well, I've heard
That's
that
not how
they've been
positions-
told not to contact us directly. They should go through their ledge office. Last question, I guess. Staffing question, because it pertains to things like our state mental health facilities. So Disability Rights Maryland is currently suing the state, which you're aware of, over delays of moving people who are found incompetent to stand trial to state hospitals, that there's this delay, obviously, that we're all aware of. I currently have a constituent who was found to be incompetent to stand trial a month ago and has been in jail now, in our local jail, for about 9 months, including a month after the judge's determination that she was not able to stand trial. She's still waiting for the department to be able to find a place for her to receive mental care. In the meantime, she's kind of decompensating in our local jail system. What specifically can the state do to help increase the speed at which these individuals are being transferred? Because they're supposed to be transferred within the statutory 10 days, but we know we have a lot of patients, including my constituent, who's languishing in local jails because of this.
So the one thing, and if I can send you all the details and send it to the committee, but the number of evaluations that are happening has increased significantly over the last couple of years, and the number of people that are being deemed incompetent to stand trial exceeds the capacity in all the beds that we have in the state. So even if I were to clear out every single bed, we still wouldn't meet the demand based on the number of evaluations that are coming in as incompetence to stand trial. Right now, my wait list as of today, which we get every single day, or as of close of business yesterday, was 217 people. We have since decreased that significantly based on some efficiencies we've gained in moving people around under Deputy Secretary Lord and the Behavioral Health Administration. But even with those efficiencies, the wait list is still over 200 people. I will say that in addition to the number of people deemed incompetent to stand trials, when we've had issues or cases when we've deemed them competent to stand trial, and then the public defender will get their own evaluation, and then they're deemed incompetent to stand trial. So that's one. In addition, we've had issues when we're ready to discharge, waiting for the judge to sign the order, and we have lots of examples where we've deemed them competent, but the judge has disagreed with our opinion and said that they should stay in our facility. So it's an incredibly complex system that's not working right now, and we have multiple people weighing in on whether someone stays or goes in one of our facilities, which is adding to length of stay. So I don't have an answer for you today, other than to say we have a significant waiting list of people waiting to get into our facilities. We have staffing issues. Even though we pay very well in our forensic facilities, not everyone wants to work in a forensic facility. And then we're also competing with our healthcare systems in the areas where we have facilities for the same staffing, such as nurses and social workers and psychologists especially.
Okay. Well, I mean, as you know, the decision of competency is decided by a judge, not technically by MDH, right? So I know you've had some concern with how judiciary
is done by the psychologist, the psychiatrist that's evaluating the patient for competency to stand trial.
Senator, just a minute. She's trying to answer your question about competency.
I hadn't finished my question yet, but go ahead.
Only one of you can speak.
Go ahead.
At a time.
Competency is determined by a judge, right? So every patient has a constitutional right to be determined whether they can stand trial or not, and that's determined by a judge, not technically by the department, right? So I know that you have I think, ongoing conversations with the judiciary about how to, how they might want to look at whether people are competent to stand trial or not, but ultimately it's the department's responsibility to receive these individuals that a judge has decided is not competent to stand trial.
So I will say that judges are opining on competency at a rate that exceeds the current bed capacity that we have in all our facilities.
But that's not the judge's fault. That's the department's responsibility to receive those who have been determined to be incompetent by the judiciary.
I don't have an answer to that.
It's about not having enough places, isn't it?
We don't have enough placements. We do have, as I mentioned, we have psychologists and psychiatrists are the ones doing the evaluations to determine competency to stand trial. We have judges that even when we say they are competent, public defenders and judges getting second opinions with other evaluators, and then sometimes those decisions are changed to incompetent to stand trial. So our IST numbers are going up at a rate that exceeds the bed capacity that we have today.
On that last point, then, what is the plan to deal with bed capacity? Because we understand that Spring Grove, for example, is going to be shuttering in a couple years. It's a couple hundred beds that are going to be taken out of the system. We don't have enough beds now. What's the plan to deal with a future loss of a couple hundred beds later when we're already in a deep hole?
So I just want to be clear on Spring Grove, and that was the UMBC sale that happened under the prior administration, and that is 10 years. I think we're probably in year 3 of the first contract, and then there are 5 renewable option years, and we will need all that time to develop another facility for those individuals in that facility. There are plans related to fine-in and expansion and conversion of some of the medium security beds at Perkins to higher security beds, but even with those beds coming online, it's not in the hundreds. We're talking about 40 more beds, or I don't have the number in front of me, but I certainly can share it with you in the next couple of years.
So I'd be curious to hear, and maybe for a future briefing, what is the plan to deal with the inadequacy of beds? This relates to staffing that we're continuing to see, because you can increase beds, but if you don't have the staff, you can't staff those beds. It just seems like there's no specific plan to address the inadequacy of beds. How are we going to increase this? I know you have ability to extend the use of Spring Grove, but we're probably a few hundred beds short now, and even opening up additional beds in Perkins is a small part of trying to solve a very large problem that, you know, just haven't heard any specifics of how we're going to try to address.
Well, one of the things that we worked on last year that passed was assisted outpatient treatment. On any given time, our wait list is about 15 to 20% of misdemeanors. And so we think as that will certainly be an opportunity to decompress the list, because people end up timing out of their charges while they're on the wait list when they could be getting services in the community. So we think that it will be one tool in the toolbox. We certainly have sat down with the judiciary and others in the General Assembly to think about what is the right way to provide care. I just want to say over the last 20 plus years, we've closed many facilities with always the intention of rebalancing in the community, and that didn't happen. And so we're trying to solve multiple problems, and how do we address these problems upstream before they get arrested for some of the things that they're doing, which are secondary to their untreated behavioral health, and how do we stabilize people in the community so they don't commit those crimes? But then once they commit the crime and they're deemed incompetent to stand trial, how do we work with the jail wardens and others to provide services while we work on discharging patients from our facilities? We're looking at our own length of stay and what are the opportunities to improve the treatment that's provided in our facilities to decrease that time, but then also community supports. Many of those community supports went away during COVID, and so it even makes discharging on the back end more difficult than it used to be. So it's a confluence of things that are happening all at once that have driven up our wait list, but we are actively working on all the things that I just mentioned.
So assisted outpatient therapy, though, only helps for folks prior to them being arrested. We still need places to go if they're arrested and found incompetent to stand trial to have somewhere to go.
So for our 15 to 20% of misdemeanors, and even for our non-criminal, non-sexual crimes that are charged, many of them have been arrested for misdemeanors prior to that. If we had had the opportunity to intervene in community behavioral health services, we could have avoided the larger charge that led to the evaluation. So there are things that we're trying to do upstream to prevent the arrest and getting going through the system.
But I know the budget just came out yesterday. We're still waiting on a full briefing on it. But was there any more money asked in the budget to address this backlog of individuals being able to find a state psychiatric bed?
Outside of the construction that I've already identified, there are no additional dollars again, we're still going through the budget as well, but no additional dollars outside of the additional beds.
So there's no additional dollars to try to address this problem in the budget proposed?
As I said, the problem is more complex than just adding more beds.
Totally understand that.
Okay.
Okay, but you need resources to be able to deal with this. Okay.
Thank you, Senator. Before we go to the fifth topic of today, I hope you've been listening to the Secretary and the issues that she's been dealing with in the 2 short years that she's been our Secretary. She's had staffing issues. We've had OHCQ not able to do any of the surveys, much less the ones I was concerned about, the transfer to private equity. She's dealt with the DDA self-directed services and the expense, the Medicaid update and having people go through that system and be reevaluated. It's just, and then there was the Kaiser issue with, we almost had 108,000 people looking to change MCO. So I know it's a lot, and I know we have a lot of issues, but the Secretary has had to handle a tremendous amount of issues in 2 years. I think number one being the staff was skeleton staff. I mean, there was a lot of staffing issues, and you can't do the work without the staff. So now we're going to go to question number 5, which is one that I put on, and it's the licensure of substance use disorder programs. And Madam Secretary, I'm asking this question particularly of the incidents we saw in Baltimore with the PHA that were, I think we funded a grant providing housing, but they were supposed to be doing healthcare issues on the side of, the drug issue. So my question really is, once these companies, these nonprofits or these companies come to Maryland and are given a license to handle mental health issues or opioid addiction, the addiction issues, what do we do for oversight? What are we inspecting to know that they're doing their job? Because obviously this particular facility was not doing their job. Thank you.
So first, before I turn it over to Deputy Secretary Lord, I just want to thank you for that acknowledgement. And I want to say, even though we've had a lot of problems, we've also done a lot of really great things. And at some point, I would like to come back to talk about all the great things and the enhancement of services that we now have for Maryland residents in the behavioral health system, expanded benefits in Medicaid, the right sizing that Deputy Secretary Marlena Hutchinson has done in DDA, the work that Dr. Kalyana Raman has done in public health with protecting women's right, with maternal child health, with health equities. We signed the AHEAD deal. So there's just been a lot of really good stuff. And I know sometimes it's easy to just focus on the negative stuff, but we have improved healthcare and healthcare access in the state of Maryland in 2 years we've been here. But I really, really appreciate that acknowledgement. So thank you.
Thank you, Madam Secretary. And I appreciate that you have often called me and updated me on issues that you see on the horizon. But I do know it's a lot. We'll have to have you back and go through the list of the good stuff.
I would love to come back and do that. And with that, I'll turn it over to Deputy Secretary Lord to answer your question.
So good afternoon, Madam Chair, Vice Chair, and members of the committee. And Madam Chair, I do appreciate your question. This is something that over the past year, the Behavioral Health Administration has been working to right size, which is looking at, we are ensuring the quality, performance, and outcomes and oversight of the behavioral health providers that are being licensed in our communities to render services for those that are in need of mental health and substance use supports. And so with that, I'd like to take a few minutes to talk with you about what we've embarked on over the last 12 months. What I can say from the outstart is that for the provider that you've mentioned, it is an active, ongoing investigation, so I can't provide further commentary as it relates to that particular provider. But what I can provide is the framework of the work that we've been doing. And before I do that, though, I'd like to do just a little bit of level setting around the licensing overview. And so behavioral health licensing lives under COMAR 1063, which are the regulations that were promulgated for community-based behavioral health providers. And this is for both accreditation and not accreditation-based licenses. And what happens within the Behavioral Health Administration is when an application is received, and depending upon the type of service, and you'll see a subset of the services that we license in the next slide, it is issued based upon a specific date range, a period of time in which it must be renewed, based on their governing regulations. And I'll talk a little bit later on about the massive amount of work that we've undertaken over the past 9 months around revising those regulations. And for reference, BHA currently licenses more than 1,000 community behavioral health providers across more than 5,000 locations across the state. And this is inclusive of all application types. So whether it is a brand new provider to the state, whether they are renewing, relocating, mergers, acquisitions, so on and so forth, that flows through the Behavioral Health Administration. This is a subset of the various different licensure types that are issued by the Behavioral Health Administration. So we have our outpatient mental health centers, mobile treatment services, supported employment, and residential crisis. And again, some of these are accreditation-based licenses, which may go through CARF or the Joint Commission, and such programs such as residential crisis are non-accreditation based. And some of you may be aware that, I believe it was in 2016, there was a change to the COMAR regulations that took away some of what I think the Secretary has referred to as the teeth behind the ability of the Behavioral Health Administration to really ensure that we are providing that quality and oversight and monitoring that we'd like to have as we've moved towards accreditation-based licensing. And with the upcoming revisions, we are hoping to COMAR 1063, we are hoping to address some of those teeth that had been taken out. And so what I've provided for you here as it pertains to, gosh, I am not good at driving this. Let's hope I'm better at driving a car. For said residential treatment services, this indicates the various levels of intensity of services. These criteria are laid out by the Association for Addiction Medicine, otherwise known as ASAM. So you might see that in certain places. So what we have here is for level 3.1, for example, that is our lowest level of residential treatment. And these are predominantly for individuals that have the ability of self-care and that they are most likely living independently, but need additional supports and get that for a minimum of about 5 hours a week of supports or services. And so what we'll find is with each successive level, the number of hours of services that are provided. So for example, for 3.5 and 3.7, it's a minimum of 36 hours per week of services that must be provided. It's also indicative of an individual's level of addiction or need of services. So for those that are in the 3.5 or the 3.7, for example, they need intensive supports that requires them to have 24-hour care. And it also means the clinical staffing pattern is more reflective of them having regular engagements with physicians, nurse practitioners, nurses for med management. The lower levels of care, they're receiving that, just not at the same levels of those that are in the more intensive 24 hours of support. And so when you talk about, Madam Chair, when you talked about what are we doing to oversee these providers, so we actually have a dedicated office of substance use compliance within the Behavioral Health Administration that lives under licensing. So we have a dedicated team that is conducting regularly scheduled audits and reviews. We are working in partnership with our local jurisdictions around enhanced funding to support these programs, which is also inclusive of them making sure that they have the assets and resources to go and conduct the site surveys and report back on what the findings are. Oftentimes it is done in partnership with the Behavioral Health Administration. They are responding to the constant inquiries that we're receiving regarding the interpretation of COMAR. I don't know if any of you have had the distinct pleasure of reading COMAR 1063, but it is, in all of your spare time, I'm sure during legislative session, add it to your list. But it is a complex set of regulations to navigate. And so our team is helping our providers help to ingest and then render those services. We're providing technical assistance, not only to our local jurisdictions, but to our providers. And then we're also working to make sure that we triage those complaints appropriately and then assigning them to the appropriate level of intervention. And then we are also working in partnership with the Office of the Inspector General and our state licensing boards for those complaints that warrant a higher level of intervention, such as the issuing of cease and desist, termination of licensure. And while I can't share a distinct number, what I can say is that over the last 12 months, the number of providers that we have referred to the Office of the Inspector General is about 80% higher than what we had submitted in previous years. So we have been working diligently to make sure that not only are providing technical assistance and training to make sure our providers are good actors, right? That they are successful in providing quality care. And the Secretary mentioned all the work that we've been doing to make sure that Marylanders are getting access to quality of care. It starts with that interaction of making sure providers are getting the training and technical assistance. But we also know that we have some bad actors that spoil it for the good actors. And most importantly, it means that Marylanders are not getting access to the quality of care that they deserve, especially for those that are struggling with substance use disorder. And so I would be remiss if I didn't mention recovery residences. So I think some of you have been privy to the presentation that either myself or the Secretary has done around the behavioral health continuum of care. So access to residential treatment services is one part of the overall recovery for individuals. And one of the other pieces, and as we discuss the different levels of care, there are individuals, once they leave residential treatment, that they need a step down or they need a transition of care. And in many instances, we find that they are transitioning to recovery residences. And now recovery residences have a very broad definition. And while there is a national recognition of recovery residences, and there's actually a National Association of Recovery Residences, nationally, recovery residences have been a bit of a polarizing subject, not only because of the NIMBY implications, but also because many states have contended with this notion that recovery residences can be both certified and not certified. And so Arizona, for example, had passed legislation requiring that all recovery residences be certified, and that was met with a lawsuit filed by the recovery residences. But what I do want to just frame, and again, recovery residences live in COMAR 1063. We're actually working on revising those COMAR 1063 regulations regarding recovery residences so that we are more clear and distinct on what defines a recovery residence within the state of Maryland. And it really is a place for individuals to land as part of their recovery to receive the additional wraparound supports. That also being said, there are different levels of services that are provided within recovery residences. So we have peer-run, we have monitored, we have supervised, and we have service providers. And so with each of those comes their own distinct levels of care, and I'm happy to provide more information subsequent to this briefing if you'd like more information on the various levels. But what I can say is that in the state of Maryland, certification is required for any recovery residence that seeks to receive state funds, operates as a certified recovery resident, is advertising themselves as a recovery residence, and has implied to the public that they are a certified recovery resident. So they have to go through the complete process, which also has enhanced protections in order to receive those state funds. So with all that I've said, what I will say is we know that there are barriers and challenges with some of our providers in our community. And so what we had done is in July of 2024, we had partnered with Medicaid to submit a request to CMS for the pause on new provider enrollment for a subset of provider types. What we had found was that within the subset of provider types of PRP, PHP, and IOP and PRP health home was significant concerns related to Medicaid fraud, waste, and abuse. And if we also think about how we manage the outcomes of our patients, and if we're investing in more community-based behavioral health services, then what we would hope to see is a decrease in total cost of care, a decrease in emergency department utilization, a decrease in inpatient utilization for behavioral health stays, and it wasn't correlating. And so when we took a look at a subset of claims and utilization across these four providers, what we found is out of 1.1 million in claims, over $600,000 of those claims were retractable. And as I'm sure you can imagine, some of these services have expenditures that exceed more than $400 million annually to the system. And so we wanted to ensure that we were right-sizing how we thought about licensure. And so with that, what it meant was that providers could not enroll in Medicaid. So they could receive licensure, but they could not then subsequently enroll in Medicaid for reimbursement for services. And much of this work really focuses, and you've heard me mention this, on COMAR 1063, because we need to buttress our licensing process so we have the necessary protections. The other piece, and the Secretary just talked about staffing and vacancies, we need to be able to ensure that we are bringing on new team members to help support this process. More than 1,000 applications annually, more than 3,000 providers with more than 5,000 locations across the state. And so there's some investment that we're making across the various different levels of review to shore up that staffing process. We are also trying to move the Behavioral Health Administration into maybe the 20th century, maybe the 21st, with streamlining some of our processes. We've been antiquated in having paper processes for all of our applications, which creates some delays. And so we're moving, come February, towards application automation. And then for COMAR 1063, this has been a process over 9 months, of which we had done 3 months of intensive stakeholder engagement. We had more than 300 individuals attend sessions, and we've received over 900 comments to date on the revisions that we're proposing. And so that work is going to continue, and we're hoping to finalize that come this spring. It will go back out for public comment. And then you heard me mention we're doing a lot of work around supporting our providers in the community on quality and compliance and increasing the number of audits that are being done. And with that, I am happy to take any questions.
Thank you, Deputy Secretary. So was this PHA a certified recovery residence?
They were not.
Oh. So we have certified recovery residents, and we have some that are not certified. They're just allowed to operate?
That is correct.
Are they getting federal funding? Where's the money coming from?
So what winds up happening is for those that are certified, they're eligible to receive state funds, and they go through the application process and so on and so forth. For recovery residences that are not certified, what oftentimes happens is either the individuals staying there pay rent, or they negotiate some of their benefits or entitlements to be able to receive the services.
Wow. And do we have any regulation that prevents us from having recovery residents that aren't certified?
Not to date.
Should we have?
I think that is an ongoing discussion. And we also know federally there are some conversations that have been transpiring at the federal level around what the approach should be around non-certified recovery residents.
You know, I think about the people that are either paying or their families are paying, and they're expecting to get recovery service. They want to get better. They've made this decision, and yet they're not getting help. It's really sad to think that, you know, that they're willing to try and they're not going to make progress. So thank you for your presentation. Senator, you have a question?
Thank you, Madam Chair. thank you for the presentation. I've only recently really learned the 3.1, 3.3, 3.5. To piggyback on what was just discussed, if a service provider is receiving Medicaid, do they have to be certified? Or maybe ask that question reversed. Do you have to be certified to take Medicaid or no?
So if a provider is licensed by the Behavioral Health Administration, based upon that list of provider types that I've listed, and happy to provide for you the list of provider types that also bill Medicaid. So we have some, for example, residential crisis, for example, does not flow through Medicaid. It is a state-funded service. So
Right.
there are various different types of licensure type and those services that are allowed to bill Medicaid.
Okay. If one of these providers that we're discussing, if there's a concern that they're not doing what they should be doing, what recourse does the state have, do you have with them?
So within the Behavioral Health Administration, there are a couple of different paths that we can choose. I also just want to highlight that there are a number of different ways that individuals can report grievances, because I also think that's an important part of this process, is making sure that we're empowering our patients or their family members that if they have concerns about the care that they're receiving, that they can report it. So every provider is required to have a grievance policy that is posted and shared with patients. Patients can also, or even we've had staff members of facilities report complaints or concerns around their own employer. But that being said, they can contact the Behavioral Health Administration anonymously. They can contact the local behavioral health authority, and they can also contact Carillon. And we, across all of us, we investigate those complaints.
Okay, and if with a type of complaint, could a type of complaint be they're only cleared for 3.1 and 3.3, but they're providing 3.5?
They can't provide 3.5 if they're not licensed to provide that service. And so oftentimes.
But what if they were? I'm just trying.
Well, then we would have the ability to intervene. So we would be able to issue, for example, a cease and desist.
Even if whether they're certified or not, right?
Well, they
Or
have
no?
to be, are we talking recovery residences, or are we talking the 3.1, 3.3, 3.5?
I think I'm talking recovery residences. And I'm not trying to get down a rabbit trail. I'm actually curious because anyway, yeah.
Yeah, so recovery resident, okay, so to separate, my apologies, I thought you were talking about the different clinical levels of service. So for not certified recovery residences, the state has very little that we can do to intervene.
So the health department cannot, and I speak globally, not you two sitting here, the health department, even the local ones, they can't go in and inspect them, or?
They can, or it can be raised at the local level through zoning, whether or not, if they are operating a residence that doesn't align with local zoning laws. But the thing we also want to be mindful of is that these are individuals that may be in need of these recovery resident services. So how do we make sure that if they're not certified, how are we transitioning them to the right level of
Totally
care?
agree. And then I think because we're having a challenge with folks, companies that operate, I'm calling them companies, but these organizations that operate, that if they're not certified and they're not really regulated by anybody, and they can set up a bunch of group homes, hypothetically in a neighborhood where there's no HOA, they could set up 4 group homes, and there could be great concern that the residents are not really getting the kind of care or perhaps the kind of oversight that are needed. But those residents are not going to complain, but the people who live around them would complain. Is there a way for people to complain that might be next door to or near?
They can surface those complaints with the local behavioral health authority, with the local health department. That is managed at the local level. And
Right, but if the local health department then the local health department can go investigate if there's,
Yep.
and I understand nobody ever wants things in their neighborhood, but, I'm trying to figure out just curious about an organization, so. I
at the
appreciate it.
local level, they can go and investigate. Absolutely.
Okay, thank you. Thank you, Madam Chair.
Thank you, Senator. And Senator Lamb.
a lot of this is stemming from the report that was in the New York Times Baltimore Banner regarding PHA healthcare. And, I know there are probably things that you can't talk about specifically to PHA healthcare, but, more broadly, just trying to understand, because I think it falls under the recovery residence certification, how they were able to continue to function for so long while there were deaths of individuals. And it was a company, to Senator Reedy's point, that seemed like they were kind of gaming the system. They were offering free housing to individuals while being able to bill Medicaid for providing behavioral substance use disorder treatment, right? And so those two should not have been tied naturally together, but they were able to kind of skirt under the radar, offer housing to individuals, and then supposed to be offering substance use treatment. But it seemed like a lot of that was done virtually through maybe not even licensed providers that were in foreign countries via Zoom, et cetera, et cetera. How was this, and how do we ensure that other groups are not functioning in this regard and continue to function in this regard?
So Senator Lamb, I appreciate the question, but I'd also like to lift us up away from PHA, because as I said, that's an active, ongoing investigation, and I can't comment. But what I can say is that this ultimately ties back to COMAR 1063 and needing to shore up some of the regulatory pieces. And there are challenges that we currently have within COMAR 1063, for example, that if a provider's license is expired, as long as they've submitted the application, which, by the way, our team within the Behavioral Health Administration is tracking that, and also sends reminders to the provider saying, oh, by the way, your license is set to expire. So I think it more so speaks to the partnership that the Behavioral Health Administration is trying to have to make sure that we're maintaining the licensure within our provider network. But it also means that we then have providers who operate potentially off of expired licenses because they're not submitting their documentation until after the license has expired. So there's work that we need to do to make sure that we're tightening up those regulations so that providers are held equally accountable for making sure that their licensure is up to date. The other thing I'll say is this is a broader issue that we've been contending with around providers that falsely incentivize services. And so we've been tackling this by a number of different ways through our licensing and compliance office. We've also met directly with providers where we've seen social media or Facebook postings of come get services and we'll give you $25 or we'll give you a proportion of the Medicaid reimbursement that we receive. Because unfortunately, the word on the street is that you can give basically de facto kickbacks to patients. And for those that are particularly vulnerable, the idea that I'm going to go get services and get care and that I'll get $25 for attending this work group can be something that's seen as an added benefit. So I think there's work that we will continue to do. It's not I think, we will continue to do to try and figure out how we detangle the housing component from the service provision. Because we do often find that those are two that are the most intrinsically linked. And for some levels of service within ASAM, they do have the ability to have the treatment be provided within the facility. They have the ability to have treatment not necessarily be within their facility, but have key partnerships, or they have to have a separate location where they're providing, where there is the housing. But ultimately, it also needs to be patient choice so that individuals know that they don't have to get services at the place where they're living.
But they're bad actors that apparently are, in essence, bribing patients, whether it's through kickbacks from their Medicaid reimbursement or, in this instance, the PHA healthcare giving them free housing to bring them into these residences that are, I guess, uncertified recovery residences. What is the actual plan to deal with COMAR 1063? Because you said that, there needs to be tightening up. What's taking place? Are you going to tighten up this reg, or do you need legislation to look at this and make sure that, those types of facilities would not be able to function? Besides the reassurance that you're looking at, what are you actually doing?
So as I mentioned, we anticipate the release of COMAR 1063 come the spring. So we've been working to revise the regulations over the past 9 months. inclusive of the recovery residence regulation.
Okay. And, obviously this was hopefully an aberrant case that isn't occurring too frequently, but I think there are concerns because you've heard these examples too of other kickbacks and other incentives that are, probably improper to be given to patients. Has the department found and required other companies to also stop providing these services or not be reimbursed? And how many others have you issued cease and desist for?
Well, so can't disclose that information, but what I can share is the increased volume, as I said before, for providers that have been referred to the Office of the Inspector General.
So you can't tell us how many other similar companies have been told to cease and desist?
Not at this time, because part of it is also tied to active investigations of those providers.
But I'm not talking about the active investigations. How many in the past, have been issued cease and desist in addition to PHA Healthcare?
I would have to go back to the team and get you that information.
Okay. Because if there's so many, and granted, generally we want to help these people, right? And most programs are helping these people. There are bad actors, right? So the intention here is to try to catch those bad actors and get them to stop. In the instance of PHA Healthcare, they were able to skirt under the rules, right? They were told that they were now unlicensed because of, follow-up from the department, but then they changed their address, was able to kind of continue doing what they're doing under a different kind of address, getting a new license, so to speak. But, that got to a point of having to issue a cease and desist. Would like to know how many other companies, again, not prospective, right? I know there are active investigations going on, but can you tell us how many in the past, under similar circumstances to PHA, when it comes to these type of uncertified recovery residences, have been issued cease and desist as well?
Let me take that back.
Okay. And when do you expect to begin, relicensing some of these? Because you said it's on pause now until June of 25, is that right?
So the pause on new provider enrollment has been extended through June of 2025. We have deliverables that are owed to CMS. One of them is Comar 1063.
Got it. Okay, so you're pending update to that reg to be able to reopen that up, I guess, and that's owed back to CMS?
Correct.
Okay. Have you increased the number of in-person inspections?
Yes, sir.
Yeah, okay. Okay, all right, thank you.
Thank you, Senator. And the last question is going to come from Vice Chair Hayes.
Thank you, Madam Chair, and it won't be as long. First question, really quick. I know a couple of years ago we established an Office of Inspector General in the Health Department. Is this one of the things that they would investigate, or?
So yes, the Office of the Inspector General is where we're making the referrals, but my understanding prior to taking office that the Office of the Inspector General no longer sits. I mean, they physically sit, but they don't report through the Health Department.
Clear.
But that's where we are making the referrals.
Got you. Okay. As a follow-up to this, and I don't expect you guys to respond, I know this, in the interim, I read an article whereas there's a facility that's in the city, Baltimore City, that I believe is proposed for Montgomery County Health Department to operate for adolescent behavioral health. I'd like to get some better understanding. I don't need a response right now. But the other thing, and lastly, I would just more of a comment than anything. I contacted, I think it was Sarah Case Haran, your legislative person, during an interim, very frustrated, not very frustrated because of like past interactions with BHA. She organized a meeting with Deputy Secretary Lord and some other young lady. I was surprisingly very impressed with the responses, like I said, I contacted them initially frustrated because of a constituent, and I thought that the same business as usual and frustration that had been carrying over years with BHA still exists. And I was surprised to find out that that was not the case and that we had made great strides in doing some significant great things in BHA. And so I thank you for that interaction, and really appreciated you all's responsiveness in that regard. So.
Thank you, Vice Chair Hayes. And if I can, just on the facility in Baltimore City. So we had done a deep dive looking at all our work and where we were providing services and who we were providing services for. And one of the deficiencies we noted in the state that if you were an adolescent with a substance use disorder treatment that needed inpatient treatment, we had nothing to offer you in the state of Maryland. And you had to go out to another state for services. We partnered with Montgomery County, was working on this issue simultaneously to us working with the issue. We partnered with them. It's in Baltimore City because that was the only provider that was willing to take on the adolescent work. And we now have 15 beds in the state of Maryland for adolescents with substance use disorder that needs inpatient treatment. And a year ago, we didn't have that. So it's only in Baltimore City by virtue of the fact that that was the only provider that said yes. But we are partnering with Montgomery County in the first year to pay that provider. And then the work will move over to the Behavioral Health Administration to continue to support that work. Sure, we'll give you all the details.
Seeing no other question, that ends the briefing today. Thank you, Madam Secretary, and for your team and for all the answers. We appreciate it. And now, committee, we're going to just take a short break while the computer system switches over to the bill hearing. Thank you.